Hey there, and welcome back to the Deep Dive.
Hello.
Today we've got quite a stack of source material here. We're looking at something really common, actually those physical symptoms that, well, doctors sometimes struggle to pin down to a specific cause.
Yeah, it's a space that can be really frustrating, I think, for everyone involved.
Definitely. So we're diving deep into one particular source today.
Okay.
It's a Dutch primary care guideline, and it focuses on what they call somatically unexplained physical symptoms, or SOLK.
Right, and it's a topic that it affects a surprising number of people, whether you've experienced it yourself or, know someone who has.
Exactly.
This guideline gives us a really structured look, actually. It's how primary care doctors, at least in the Netherlands, are guided to approach this. So our job really is to unpack it, get past the clinical jargon, and pull up the main ideas for you.
And honestly, right away, there's a stat in here that just jumped out at me. The source says that, get this, somewhere between 30 and 50% of visits to a family doctor involve symptoms that don't have a clear physical explanation after, the initial checks.
Wow, 50%, that's a lot.
It is. And it's not just primary care. It says specialists, neurologists, cardiologists, you name it. They report unexplained symptoms in maybe 40 to 60% of their consultations.
That's incredible. It really shows how widespread this is, doesn't it?
It really does. And the source also mentions, kind of interestingly, all the different names these symptoms have had over time. It sort of hints at how complex it is and maybe how confusing our understanding has been.
Yeah, the terminology itself tells a story.
Okay, so let's get right into it. What is SOLK according to the specific guideline? How are they actually defining it?
Well, the core definition they provide is physical symptoms that have been going on for longer than a few weeks, and crucially, where an adequate medical workup hasn't found a condition that sufficiently explains them.
Sufficiently.
Yeah.
Okay.
Yeah.
So it's not quite saying there's nothing wrong. It's more like standard medical tests haven't found a clear physical disease that fully accounts for what the person's feeling.
Exactly that. They frame it as a working hypothesis, after they've reasonably looked for and ruled out physical pathology, at least for now.
Right.
And here's a really important point the source makes. SOLK can also apply even if someone does have a known medical condition.
Oh, how so?
Well, if the symptoms they're experiencing or the limitations they have because of them are much more severe, or they last much longer than you'd typically expect just from that known condition alone.
Ah, okay, that makes sense. So it covers both the we can't find anything cases and the we found something,
Yeah.
but it doesn't explain this level of symptom or impact cases.
Precisely. It broadens the scope quite a bit. And the guideline really hammers home that SOLK is always just a hypothesis. Always. Meaning, if the symptoms change or if new alarm signs pop up, things like unexpected weight loss or maybe new neurological issues, the doctor absolutely has to go back and look for physical causes again. That door is never fully shut.
Got it. Okay. Now, the source also mentions classifying SOLK
Right.
by severity, right? Mild, moderate, severe. How do they draw those lines?
Yeah, it's not just about what the symptom is, but more about the impact. The main factor is the degree of functional impairment. So how much do these symptoms actually limit your daily life, your work, social stuff?
Okay.
It also considers how many different symptom clusters are involved and naturally how long the symptoms have been going on.
Symptom clusters, what kind of areas are we talking about?
The source groups them into four main categories. There's gastrointestinal, so things like stomach pain, nausea, bowel problems.
Mm-hmm.
Then cardiopulmonary chest sensations, feeling your heart race, shortness of breath. Musculoskeletal, which is, muscle aches, joint pain, back pain, feeling weak.
Right, the common ones.
And then a general category for things like persistent fatigue, headaches, dizziness, trouble concentrating, that kind of thing.
So someone with mild SLOK might have, say, some gut issues that are annoying but don't stop them working, whereas severe SLOK could be like debilitating fatigue and pain across multiple areas for years.
Exactly. And the guideline does say these severity levels aren't, super rigid boxes. They're based on clinical consensus, and it's more like a spectrum.
Makes sense. Okay, this is where it gets really interesting for me. The why. The source is upfront that there's no single easy answer for why SLLK happens. But it talks about different models, different ways of thinking about it. What are some of those ideas?
Well, a really central idea they discuss is the biopsychosocial model,
Okay.
which is basically the perspective that health and illness, too, isn't just about biology. It's this complex interplay between Biological factors, psychological factors like our thoughts, feelings, behaviors, and our social world, our environment, they all influence each other.
So it's moving beyond just looking for a physical defect and saying our minds, our stress levels, our relationships,
Hmm.
they're all part of the physical health picture.
Absolutely. It's a much broader, more integrated view. And within that, the source mentions more specific ideas, like the stress model.
Pretty small.
Yeah, linking things like chronic stress, maybe from work burnout, directly to physical symptoms like fatigue or pain.
Okay.
And then there's what they call the perceptual cognitive view. This one's fascinating and talks about how someone might get stuck in a kind of vicious cycle.
How does that work?
Well, it involves maybe paying too much attention to normal bodily sensations, then interpreting them in a really catastrophic way, like thinking a small pain must be something terrible,
Right.
and then having lots of worrying thoughts about it. That whole process, the focus, the negative interpretation, the worry, can actually amplify the original sensation and keep the symptoms going.
Wow, a vicious cycle. That's powerful. Like if you worry about your back pain, you might tense up without realizing, which then makes the pain worse.
Right.
Which just proves your worry was right. So you worry more, tense more.
Precisely. The source really emphasizes these feedback loops. How we interpret symptoms and what we do about them, like maybe avoiding activity because we're scared it'll make things worse, can be key in keeping the problem going no matter what started it.
Interesting.
It also mentions something called sensitization.
Sensitization.
Yeah, the idea that repeated pain or discomfort signals can actually make the nervous system itself more sensitive over time, like the body's internal volume knob for discomfort gets turned up.
And the source even links this back to emotions and earlier life experiences.
It does. It suggests that maybe having difficulty recognizing or dealing with emotions could play a role in physical symptoms showing up instead. And it points to things like difficult early experiences, maybe insecure attachment or trauma as factors that could potentially make someone more vulnerable to developing these kinds of persistent symptoms later on.
So it's painting a picture of lots of potential contributing factors interacting, not just one single cause.
That's definitely the picture emerging from this guideline, yes. It's complex.
Okay, let's shift gears slightly. The guideline talks a lot about the relationship between the doctor and the patient with SOLK. It calls it essential. Why is that connection considered so vital?
Yeah, essential is the word they use. It's because the research apparently shows that a good, trusting doctor-patient relationship actually leads to better health outcomes for these patients.
Oh, really? Measurably better.
Yes, and higher patient satisfaction, plus they're more likely to actually follow the advice they're given. On the flip side, if that relationship isn't strong, if the patient doesn't feel heard, it can lead to more complaints, more doctor hopping, less effective care overall.
So it sounds like just the simple act of feeling like your doctor is listening, taking you seriously, that can be a powerful intervention in itself, or maybe sometimes more powerful than a specific pill or test.
The source absolutely supports that idea. It explicitly says that showing empathy, validating the patient's experience, really listening these things strengthen the relationship and help patients feel understood and, importantly, reassured. Feeling heard can be incredibly therapeutic.
Okay, but what about tests? You know, patients often really want tests, blood work, scans to find out what's wrong or rule things out. What's the guidelines' take on investigations?
Well, this is another interesting point. It might seem a bit counterintuitive. While everyone hopes that negative tests will bring reassurance.
Yeah, that's the goal,
Right. But the source points to research suggesting that, in the long run for SOLK, negative tests often have surprisingly little effect on actually reassuring the patient.
Really? Why not?
It doesn't fully explain why, but suggests that sometimes a clear explanation from the doctor, combined with a plan for watchful waiting, can actually be more effective. Plus, there's always the risk of false positives or ambiguous results, especially if the initial chance of serious disease is low.
So a confusing result when you weren't expecting anything specific could actually increase worry instead of decreasing it.
That seems to be the concern highlighted. More tests aren't automatically better.
So what should happen if tests are done?
The guideline stresses that if tests are performed, the doctor needs to be really clear beforehand about what they're looking for, and afterward, explain what a negative result actually means in this context, and outline the next steps.
And what if a patient really pushes for a test the doctor doesn't think is needed?
The guideline says the doctor can agree to do a test, perhaps mainly for reassurance value, even without a strong medical reason. But, and this is key, they need to manage expectations before doing the test. Talk about what it's likely, or unlikely to show.
Makes sense. The source also mentions communication challenges, particularly around cultural differences.
Yes, that's a really practical and important point. Language barriers, obviously, can make it much harder to talk about feelings or emotional distress compared to describing, say, a sharp pain. And cultural background really shapes how comfortable people are discussing emotions, stress, family issues, or even how they conceptualize illness itself. The guideline advises doctors to try and adapt their communication style.
How so?
Maybe start with more factual questions, then gently move towards opinions, then feelings. And importantly, be open to discussing the patient's own beliefs about their health, even if those beliefs involve things like magic or religion, if that's part of how the patient understands what's happening to them.
And interpreters.
Strongly recommended. Using professional interpreters is crucial for clear and accurate communication when there's a language barrier.
Okay, so we've got a handle on what SOLK is, some ideas about the complex why, and the absolute importance of that doctor-patient connection. So how does this guideline actually suggest managing it all? What's the approach?
The core strategy is something called stepped care.
Stepped care.
Yeah, basically you start with the simplest, least intensive approach that has evidence behind it. And you only step up to more complex or intensive interventions if those initial steps don't help enough. It's meant to be tailored to the individual.
Okay, so what does step one look like in practice?
Step one is usually managed right there by the primary care doctor, typically for people with what's considered mild SOLK. It involves the doctor summarizing their findings, explaining things clearly, and then this is key, working with the patient to create a shared understanding or definition of the problem.
A shared definition, not just the doctor's label.
Exactly. It's about framing the experience in a way that makes sense to both of them. Often that means shifting the focus a bit away from the mystery illness idea towards understanding the impact the symptoms are having on the person's life and function. Step one also includes giving specific information and advice.
And what's the core advice usually given at this stage?
A big part is reassurance about the outlook, that for many people, things do improve, although symptoms might fluctuate. And a really critical message is that movement and activity are generally not harmful.
Even if it causes some pain or fatigue.
Yes. The message is that the discomfort doesn't usually mean you're causing damage. The goal is to encourage gradually, consistently increasing activity levels.
Okay. Now, the source mentioned something specific for that. A time-contingent plan. What's that about?
Yes, that's central to step one. It's a really practical tool. A time-contingent plan means you schedule your activities, say, going for a walk based on a set amount of time, not based on how your symptoms feel at that moment.
So instead of I'll walk until my back starts hurting, it's I will walk for 15 minutes today, regardless.
Exactly. You stick to the schedule. This helps break that cycle where symptoms dictate your activity level, which often leads to doing less and less over time. It puts you back in control based on time, not symptoms.
That sounds simple, but potentially powerful. Okay, so what happens if step one isn't enough, or for people with more moderate symptoms?
Then you move to step two. This usually involves bringing in other professionals, but typically still within that primary care network or easily accessible services.
Like who?
Like psychosomatic physical therapists, physios with extra training in mind-body connections, or maybe mental health workers embedded in the primary care practice, or psychologists. This step is common for moderate SOLK, where the functional limitations are more significant or things have been going on longer.
And what kind of treatments are favored then?
The source really emphasizes treatments where the patient is actively involved, things they do. So specific exercise programs, cognitive behavioral therapy strategies, things like that, these seem to be more effective than passive treatment.
Passive treatments being
Like massage or maybe injections or even surgery in some cases. The guideline suggests active approaches generally work better for SOLK.
Right. Okay. And then step three, for the most severe cases.
Step three is for severe SOLK, usually meaning significant long-term disability that hasn't improved with the earlier steps. This typically means referral to more spiralized second-line care. Often, this involves multidisciplinary teams.
Multidisciplinary.
Yeah.
Meaning lots of different specialists working together.
Yes. And the source notes that having a designated case manager at this stage can be really important to coordinate everything, make sure everyone's on the same page.
What kind of work do these specialized teams do?
The guideline points towards intensive, integrated programs, teams that look at the physical, the psychological, and the social aspects all together. Things like intensive rehab programs combining physical therapy and cognitive behavioral approaches show promise for actually improving function.
Interesting.
And it also includes a specific warning against just sending people to, say, a pain specialist who only offers local injections or procedures without addressing the bigger picture. The guideline says those kinds of single-focus invasive treatments aren't generally effective as standalone therapies for SOLK.
Okay, so pulling that whole management section together, it sounds like the approach is start simple, tailor it, really focus on shared understanding and helping the patient get active again,
Yeah.
using things like that time contingent plan. Then bring in other helpers like therapists or specialized physios if needed, especially for moderate cases. And for severe long-term situations, it's about intensive integrated teamwork, not just isolated procedures, always focusing on active patient participation.
That captures it really well. Digging into this guideline, it becomes pretty clear that SOLK isn't really viewed as just one hidden disease we need to find. It's seen much more as this complex interplay, body sensations, thoughts, feelings, behaviors, social situation, all tangled up.
Yeah.
So it shifts the focus, doesn't it? Away from purely searching for a cure for a specific thing and more towards understanding the whole picture, managing the symptoms, and really trying to improve the person's overall function and quality of life.
So reflecting on this whole deep dive, what really stands out to you? Was those initial prevalence numbers, the different models going beyond just biology, or maybe a practical thing like the time contingent approach?
That's a good question. I think maybe the most provocative idea that sticks with me is something hinted at in the source, the possibility that all these different functional symptoms, chronic gut problems in one person, persistent fatigue in another, widespread pain in someone else, they might not be totally separate issues,
We-
meaning they could potentially be different expressions of sort of one underlying process or vulnerability manifesting differently in different body systems.
Wow.
And if that's the case, or even partly the case, it really underlines why this guideline pushes for a common management approach, one that focuses on the person's whole experience, their function across all these different dimensions, rather than getting stuck just trying to diagnose each symptom cluster in isolation.
That is something to think about, how maybe recognizing that deep complexity and shifting the focus towards managing the impact of symptoms on life, rather than only chasing that single, often elusive physical cause, how that could fundamentally change things for the many, many people dealing with these kinds of experiences.